And another thing about this microcircuit is it keeps giving depolarization to this area, the ventricles. At the same time, it can also send depolarization signals upward to the atria. What did I tell you about the AV node, the SA node, and the bundle of His? Who becomes the pacemaker? The SA node, because the SA node is faster. But what I told you, right? What if someone was faster than the SA node? Who becomes the pacemaker? That thing that's faster than the SA node. And in the case of AV-NRT, it's the micro-reentrant circuit that's now the pacemaker of the heart. So as electricity keeps going round and round and round, and that's the reason why you get 200 beats per minute, because the depolarization wave just keeps. Doesn't have to travel so far. It just travels at a very, very small distance, right? And keeps depolarizing the ventricles at the same time. Does everyone understand how that works? Okay, you don't need to know basically, you know, which one's slow, which one's fast. What I want you to remember about AV-NRT is the micro-reentrant circuit that's causing the 200 beats per minute because of one normal and one abnormal track. Okay? Okay, now, as compared to a junctional rhythm. What's a junctional rhythm? Rhythm from the AV node, okay? So as compared to a junctional rhythms can only go as fast as 130. Okay, anything lower than 130 is what you call a junctional rhythm. Anything above 140 is most likely AV-NRT. Why is this important? Because sometimes, okay, you learn this. You haven't learned how to place ECGs yet, right? The leads. Have you taken up laboratory? Not yet. Okay. When we take up laboratory and you're placing ECGs, even if you are a skilled person, it takes some time. Because you have to place the chest leads, you have to place the limb leads, and all of that. In an emergency setting, you don't really have, well, you must do it, but to make an initial impression of what the patient is going through, you need to know certain rules. And in this case, if the heartbeat or the heart rate of the patient is above 140 beats per minute, then most likely you're looking at something like an AV-NRT. Okay? It's not just AV-NRT. A lot of other tachyarrhythmias can cause 140 above, but most likely that. So if you're looking at something below 130, then probably you're looking at a junctional type of rhythm. Now, what's another thing you need to know about AV-NRT? In AV-NRT, you will see what's called pseudo-S waves. What is a pseudo-S wave? What do you mean by pseudo? False. Good. So it's a false S wave. Why is it a false S wave? Anyone know? The reason why it's called a false S wave or pseudo S wave is because, well, yeah, well, remember PQRS. S always goes down. But the reason why it's called a pseudo S wave because it's not an S wave. It's a P wave that's inverted. And now we're looking at it. Why the hell would the P wave be inverted and come after the QRS complex? Let's go back to this diagram. Yeah. Remember the micro-reentrant circuit going round and round and round? So QRS, P. And you're saying, why is it inverted? Because remember, what did I tell you about direction of depolarization? If it's moving away from the lead, what direction does the wave point to? Negative. So in this case, if the depolarization from the SA node going downward to here, it is going to be a upward P wave. But if it's a depolarization that's from the opposite direction, it will then be a inverted or negative P wave. And in this case, depolarization, the ventricles get depolarized slightly faster or almost at the same time as the atria, creating a pseudo S wave. Now the pseudo S wave is very, very theoretical. Because if you look at the ECGs of actual AV and RT patients, they're actually quite hard to identify. Because they look like S waves. Okay? So just to look, an attack of AV and RT versus a normal resting ECG looks like that. Okay, so this is the normal NSR, normal sinus rhythm, PQRS. Okay, PQRST. PQRSP. There's the P wave. Okay, and sometimes even that P wave can also be inverted at times as well. Okay, so sometimes in patients, this is an actual ECG. There. Actual cardiac monitor. Note that for normal, this is normal sinus rhythm at this point. Okay, there. This is normal sinus rhythm at this point. Suddenly normal sinus rhythm, and then suddenly a premature ventricular contraction. And after a premature ventricular contraction, it becomes AV and RT. Look at the heart rate. Remember, anything over 140 is most likely to be AV and RT. Let's take it a notch up. If you see a inverted P wave and it's over 140, then most likely it's AV and RT. If you see a negative P wave, an inverted P wave, and the heart rate is only 120, then you're most likely looking at a junctional rhythm. Okay? Okay. So AV and RT, just to be clear, AV node, a micro reentrant circuit in the AV node, it then becomes the pacemaker, shutting out the SA node. Yes?
I have heard you say from that loop, they will come back to the atria, right?
Yes.
But why don't we see the positive P wave in this ECG as well as the negative?
Okay, very good question. That's an excellent question. Why don't we see a positive wave? Because technically the SA node is still firing. Remember this. In the same way that in the normal ECG, let's go back. In this ECG, do you see atrial repolarization? Remember, this is atrial depolarization, ventricular depolarization, and ventricular repolarization. Where's atrial repolarization? Okay, but I know you got the idea. Atrial repolarization in this case is buried in the QRS complex. Remember this, to answer your question, why is the negative P wave seen and not the positive P wave? Because the ECG measures the electricity current that's strongest. And in this case, the strongest current in this case is the one from the AV node. Yes, that's one that's going around and around. Another explanation for that is, remember the word overdrive suppression? I talked about that last week. Because now the pacemaker is the AV node, even if the SA node is firing, because the AV node is firing so fast, the ECG can't read the SA node anymore. It's more or less it's buried inside, you know, it's buried inside this 166 heart rate. Because the SA node fires what? 62, 100. So it's not going to be seen anymore. Okay? Note this about AV and RT, another thing you need to know. The R and R